Good afternoon. This subcommittee will come to order. Without objection, the chair is authorized to declare a recess of the committee at any time. This hearing is entitled U.S. Biodefense Preparedness and Implications of Antimicrobial Resistance for National Security. And I want to apologize, first of all, to my witnesses, our witnesses, and to our guests. As you know, there's a rule, as I explained earlier to most of our guests, there's a rule in the House that a subcommittee hearing such as ours cannot convene while there is a full committee hearing ongoing. And so that's where my colleague, Mr. Heiss, was. There's also a rule that a subcommittee cannot begin unless one Democrat and one Republican are present to constitute a quorum. So I have to say I have never been so happy to see a Republican in my life. So we will begin. Today's hearing will examine whether the United States is prepared to respond to various biological threats to our national security. These include natural pandemic outbreaks such as influenza, Ebola, or diseases yet unknown, as well as biological attacks which are perpetrated by foreign adversaries, terrorist organizations, and other non-state actors. We will also focus on the growing threat of antimicrobial resistance, which, according to the Center for Disease Control and Prevention, already contributes to the deaths of about 23,000 Americans each year. In the 2 decades since September 11, 2001, amazing developments in biotech, including synthetic biology, gene editing, and genomic engineering, have led to remarkable breakthroughs in healthcare, clean energy, and sustainable nutrition. However, actors with malign intent can also exploit those same technologies to develop biological weapons or agents and deploy them across our nation and the battlefield with potentially devastating effect. Director of our National Intelligence, Dan Coates, underscored this risk in his 2019 Worldwide Threat Assessment when he stated, and I quote, "These technologies hold great promise for advances in precision medicine, agriculture, and manufacturing, but they also introduce risks, such as the potential for adversaries to develop novel biological warfare agents, threaten food security, and enhance or degrade human performance," close quote. A previous assessment issued by former Director of National Intelligence James Clapper identified gene editing as a potential weapon of mass destruction, the basic ingredients of which can be bought online today for as little as $60. Similarly, the Nonpartisan Government Accountability Office has also highlighted the dangers posed by naturally occurring infectious disease that could easily become pandemics in view of global climate change and mass human migration. These official warnings demand our continued attention, although we are fortunate not to have experienced a biological attack here in the United States since the anthrax attacks post-September 11th, the threat remains very real. Foreign adversaries have already demonstrated an interest in developing genetic and biological weaponry. According to official reports, North Korean leader Kim Jong-un is pursuing advanced bioweapons research and production capabilities. Andrew Weber, the Assistant Secretary for Nuclear, Chemical, and Biological Defense Programs under President Obama, recently commented that North Korea is far more likely to use biological weapons than nuclear ones. The program is advanced, underestimated, and highly lethal. So terrorist organizations and other non-state actors have also sought to develop and deploy biological weapons. A laptop discovered from ISIS fighters in northern Idlib, Syria in 2014 reportedly contained a 19-page document with instructions on how to develop biological weapons and weaponize the bubonic plague from infected animals. It also highlighted the relatively low cost of biological weapons and their potential to inflict mass casualties. To their credit, both Democratic and Republican administrations have taken some steps to strengthen our national biodefense. Most recently, in September 2018, the Trump administration released the National biodefense strategy in compliance with the congressional directive, included in the fiscal year 2017 National Defense Authorization Act. The President has also established a multi-agency biodefense committee to be chaired by the Secretary of Health and Human Services. Congress has also sought to enhance our national biodefense and preparedness. Earlier this month, the House passed a bipartisan legislation that will reauthorize critical funds for bioterrorism and pandemic preparedness, including $7.1 billion for the BioShield Special Reserve Fund for the development of biothreat medical countermeasures. The bill, which the President signed this week, also includes $685 million in annual grant funding to states and localities through 2023 to assist them in responding to infectious diseases, biological events, and other public health threats. Nevertheless, there are key gaps that remain. As reported by GAO, our national biodefense framework is still, and I quote, fragmented and lacks coordination among multiple agencies. Moreover, GAO has identified persistent challenges facing two primary biosurveillance programs operated by the Department of Homeland Security to detect and monitor biological threats. Both the BioWatch program and the National Biosurveillance Integration Center have been hampered by technical performance deficiencies and the absence of clearly stated missions. Our biodefense efforts must also adapt to the emergence of new biological threats, including deadly antimicrobial resistant diseases that render existing antibiotics, antifungal, or antiviral medications virtually useless. According to an April 2019 New York Times report, the spread of a resistant fungus known as Candida auris has led the CDC to designate it as a serious global health threat. The CDC has already documented nearly 700 cases of this life-threatening infection in the United States. American service members in Iraq and Afghanistan have also contracted drug-resistant superbug infections, threatening overall troop readiness and morale. Robust and continued congressional oversight will be essential to enhancing our national biodefense going forward. To this end, I look forward to discussing these and other topics with today's witnesses, and I now yield to the ranking member of this subcommittee, the gentleman from Georgia, Mr. Heiss, for 5 minutes for an opening statement.
Thank you very much, Mr. Chairman, and I am honored to be the one Republican that you're very thrilled to see today, and the feeling is mutual towards you. I also want to take a moment to say thank you to our witnesses for your patience today and all who are attending. Sometimes our schedules get turned upside down, and the fact that you've exhibited great patience with us and understanding, and that means a lot, so thank you for that. I also want to extend a very personal welcome to Dr. Delos from the University of Georgia, a good friend and a wonderful family that you have. It's good to see you here. Dr. Delos is recognized as a great leader on this topic, as well as a phenomenal professor at the University of Georgia. And with there being about 2 months before football season, we'll just publicly say, go Dogs, and let's get that rolling. But we're here today to discuss how our country prepares for, responds to, and recovers from potential catastrophic biological incidents and naturally occurring pandemics. Historically, our country has faced a number of significant biological incidents. For example, shortly after 9/11 and the terrorist attacks then, envelopes containing infectious anthrax spores were deliberately mailed through the U.S. postal system. Many of you will remember that. Some 22 people were infected and 5 deaths occurred. In 2009, our country faced a pandemic virus that first emerged in the U.S., resulting in a worldwide death toll of between 150,000 to 575,000, according to the CDC. In 2014, there was an unprecedented Ebola outbreak in West Africa. The outbreak resulted in more than 28,000 cases and about 11,000 deaths. 11 individuals were treated in the U.S., one of which died. In September 2018, President Trump's administration released a comprehensive national biodefense strategy, as the chairman mentioned, It's built on lessons learned from the past biological incidents like the 2001 anthrax attacks and the 2009 influenza pandemic and the 2014 Ebola outbreak. President Trump has also released a national security presidential memorandum to support the National Biodefense Strategy. For instance, it established a Biodefense Steering Committee, which is chaired by the Secretary of Health and Human Services to coordinate implementation of the strategy. These actions demonstrate the administration's commitment to strengthen America's defense against biological threats to health and safety. So before us today, as I've already mentioned, each of you are experts in this field, and we welcome you here to deal with the biodefense issue. We have a Blue Ribbon Study Panel representative, Government Accountability Office, and as I mentioned, representatives from both the University of Georgia and Tufts, and we are honored to have each of you here. So we look forward to hearing your testimony and on this side of gaining some of your expertise on this topic. So again, we welcome you here. We thank you for being here. And with that, Mr. Chairman, I'll yield back.
Thank you. Today we are joined by an all-star panel of witnesses and very patient witnesses. Dr. Helen Boucher is the director of, she's my homie, Massachusetts. She's the director of the Tufts Center for Integrated Management and Antimicrobial Resistance at Tufts Medical Center. We also have Dr. Asha George, Executive Director of the Blue Ribbon Study Panel on Biodefense. Chris Curry, Director of the Emergency Management, Disaster Recovery, and DHS Management Issues and Homeland Security and Justice Team within the U.S. Government Accountability Office. His business cards are about this big. Yeah. And Dr. Kam Delos, Georgia native, University professor and director, the Institute for Disaster Management at the University of Georgia.
Go Dogs, if I failed to mention that earlier.
On the record, it's into the without objection. Go Dogs.
Thank you very much.
The record. Okay.
Thank you, sir.
All right. Now, it is the custom of the committee to ask the witnesses to rise and be sworn in. Please raise your right hand. Do you swear and affirm that the testimony you're about to give is the truth, the whole truth, and nothing but the truth, so help you God? Let the record show that the witnesses answered in the affirmative. Thank you. Please be seated. The microphones are sensitive, so please speak directly into them. Without objection, your written statements will be made part of the record. And with that, I welcome Dr. Boucher. You are now recognized for 5 minutes to give an oral presentation of your testimony.
Good afternoon. Chairman Lynch, Ranking Member Heiss, and distinguished members of the subcommittee. On behalf of the Infectious Disease Society of America, or IDSA, thank you for holding today's hearing and inviting me to testify. I'm an infectious disease physician at Tufts Medical Center in Boston, director of the Tufts CMAR that was mentioned, and the treasurer of IDSA. I also have the privilege to serve on the Presidential Advisory Council for Combating Antibiotic-Resistant Bacteria. My comments today are my own and delivered on behalf of IDSA and do not reflect the views of the United States government. As I'm a clinician, I would like to start by telling you about 2 patients we recently treated. The first is a young lady with a history of injection drug use who had 2 prior heart valve infections related to opioid use. Over the course of 2 to 3 years, she had 2 separate heart valve infections, the second of which was due to methicillin-resistant Staph aureus, or MRSA, and involved her tricuspid valve that had been previously surgically repaired. Her treatment was complicated by kidney failure due to an antibiotic called vancomycin and prolonged hospitalization. Her course was further complicated with a chest wound infection also due to MRSA. We saw her again when she was 22 weeks pregnant and the MRSA infection had extended from her chest bone into her chest. She had to have several surgeries and to receive another long course of antibiotic therapy while she was pregnant. She had several more hospitalizations, including some time spent in the ICU, but ultimately delivered a healthy term baby. Her problems have continued, however, and she may require yet another heart valve replacement. Sadly, hers is not an isolated case. We and most other healthcare facilities in the United States care for a large number of patients with drug-resistant infections related to opioid use. The second patient is a middle-aged lady I took care of in the hospital recently. She had undergone chemotherapy for leukemia and was in remission, so there was no cancer in her body. We were called when she developed pneumonia and a bloodstream infection due to a gram-negative bacteria that was resistant to every drug tested by our lab. When I sat down to deliver this news to her, she said, "How can this be? Surely you're going to find something to treat this." We did succeed in doing a lot of fancy testing in the lab and getting help from the FDA and collaborating with a company to get an investigational drug called cefiderocol and gave her a combination of antibiotics, but she ultimately died 10 days later. So this lady in the prime of her life who had overcome cancer died from an antibiotic-resistant infection. It's also important to point out that with our best efforts and help from many people around the country, including here in Washington at FDA, it took 4 days to get the emergency use antibiotic to her. And it sort of emphasizes how important it is for us to have effective drugs in our hospital pharmacies ready to use when our patients need them. These and many other experiences motivate me and my colleagues to fight for solutions to this crisis. As many as 162,000 people in the United States lose their lives every year to multi-drug resistant infections. CDC also estimates that antibiotic-resistant infections result in $20 billion in excess healthcare costs annually, due in large part to longer hospital stays for patients in whom these infections are not easily treated. Antibiotic resistant infections pose a significant threat to our national security, as was mentioned. Resistance pathogens complicate our soldiers' combat wounds, increasing the risk of limb loss and death, and compromise our military's combat readiness and effectiveness. Between 2004 and 2009, over 3,300 American soldiers in Iraq and Afghanistan became severely ill from a single resistant pathogen called Acinetobacter, which has become even more resistant to treatment over time. Alarmingly, as was also mentioned, resistant pathogens are a prime candidate for weaponization. The former Soviet Union successfully weaponized multi-drug resistant strains of both plague and anthrax. Studies have concluded that the aerosolized release of a weaponized resistant pathogen in just a single incident of bioterrorism in the Washington, D.C. area would result in a death toll of over 3 million. Any mass casualty event is likely to result in severe wounds and burns, which can quickly become infected and further complicated by resistance. Antibiotic resistance also puts our health security at risk, both in the U.S. and around the world. An outbreak of a serious resistant infection with limited or no treatment options could overwhelm health systems, harm economies, and even destabilize communities and countries. Antibiotic resistance, importantly, threatens to undo decades of medical progress. Many life-saving procedures, like cancer chemotherapy, organ and bone marrow transplants, and other complex surgeries, are only possible with the support of effective and safe antibiotics. While bacteria develop resistance in nature, the use of antibiotics places selective pressure on bacteria, leading them to develop resistance even faster. Antibiotic use in animals, agricultural settings, and the environment also contribute to resistance. We must curtail inappropriate antibiotic use to limit the development of resistance. But even appropriate antibiotic use causes resistance, so we must develop a robust, renewable pipeline of new antibiotics to address our current and future threats. Unfortunately, our toolbox of antibiotics is shrinking. Nearly all large pharmaceutical companies have left the antibiotic development field. The small companies that remain responsible for most of the antibiotic innovation are struggling to stay in business. In April, one small company, Achaogen, filed for bankruptcy, despite having received federal support to develop and launch an important new antibiotic. Others have recently announced massive layoffs. There are currently 42 antibiotics in development. Of these, only 16 have the potential to treat our worst infections, the gram-negative infections, and most drugs in clinical development do not ultimately achieve FDA approval. Factors very unique to antibiotics make it extremely difficult for companies to earn a return on investment in antibiotic R&D. Antibiotics are taken for a limited duration of time, and new antibiotics must be used judiciously to preserve their effectiveness. Incentives are needed to make antibiotic R&D feasible for companies. Congress and the federal government have taken many important steps to address antibiotic resistance and spur antibiotic R&D, and we are very appreciative. Current efforts must be maintained and new policies are needed. The problems are complex and will require multifaceted solutions that cut across multiple congressional committees. We encourage you to support the Disarm Act, which will soon be introduced in the House. This bill will help stabilize the antibiotic market for companies and investors by boosting Medicare reimbursement for important new antibiotics. It will also help curb resistance by requiring hospitals to implement stewardship programs and report antibiotic use and resistance data to CDC. While reimbursement reform would be an important step forward, it alone is highly unlikely to deliver the antibiotic pipeline we need. A new incentive not linked to sales volume to provide a predictable return on investment is necessary. We also call for increased investments in research and public health interventions to address resistance. Once again, please accept my deepest thanks on behalf of my colleagues at IDSA, and most of all, our patients, to the subcommittee for holding this hearing and for inviting us to participate. We look forward to continued collaboration to address the problem of antibiotic resistance. Thank you.
Thank you. Dr. George, you're now recognized for 5 minutes.
Thank you, Mr. Chairman, Ranking Member Heiss, and to the congressional staff. Thank you for inviting us here today to talk about these issues. I am the Executive Director for the Blue Ribbon Study Panel on Biodefense. In addition to having a doctorate in public health and having spent 30 years in the biodefense arena, I am also a Desert Storm veteran. And I bring that up really only because I know what it feels like to be operating in an arena under the specter of biological warfare. I know what it feels like to be wearing chemical protective overgarments and wonder if they are going to protect me from a biological agent. I know what it feels like to be taking a vaccine that just the week before got emergency use authorization for me to take. And I know what it feels like to be standing on a battlefield wondering if antimicrobial resistant anthrax or some other biological agent have been loaded into a Scud missile and are coming my way. I mention all of this because I don't want anybody in this country, particularly in this country geographically, to ever have to feel any of those things. And I know that you don't either. I'll just add one other point here, and that is while we haven't had any other biological attacks since the anthrax events of 2001, we still have all of these white powder events. I believe it was today that the DeKalb County Courthouse had to evacuate for what seemed to be a rather significant white powder event. That turned out not to be anthrax from what I understand, but just imagine how all of those people felt. That is a highly busy courthouse. There's a lot of people in there all affected at once. I have submitted my longer written statement for the record, but just want to make a few points here. The Blue Ribbon Study Panel on Biodefense addresses the entire spectrum of biodefense. So we're looking at prevention and deterrence in terms of the State Department and the Defense Department and the intelligence community. And then we look at everything beyond that as well: preparedness, detection, response, attribution, recovery, and mitigation. And when you hear that list, you think about what that must mean in terms of the government. This is a huge governmental set of activities. All of the federal departments, 8 of our independent agencies, and 1 independent institution that we know about all contribute to biodefense. That makes jurisdiction and oversight here in the House and in the Senate, obviously, extremely difficult and challenging. But I think that it points very directly to this particular committee and the need to exert oversight from here, because you have the entire picture and look at the entire government. We issued a report in 2015 called the Blueprint for Biodefense. In it, we have 33 recommendations and 87 action items. And we assessed the state of biodefense here in the country, looking at strengths and weaknesses and vulnerabilities. And the nation remains vulnerable to this day. In short, the nation is not prepared for biological outbreaks, acts of bioterrorism, biological warfare, or accidental releases with catastrophic consequences. And I think that's where the national security issue comes into play. Not to say that the onesie-twosie disease events are not worthy of our concern, but we are talking about catastrophic events that would affect the effective functioning of our entire society. The National Biodefense Strategy that was mentioned earlier is actually one of our recommendations from our blueprint, as was this coordination council, although you wanted to see both of those activities run out of the White House. When you have so many governmental agencies involved, we believe you need somebody above them all to run them all. The strategy has come out, as you said, Mr. Chairman, but the implementation plan for that strategy is still pretty thin. The Department of Health and Human Services has been charged with working on that implementation plan, but they face the challenge of trying to get information out of all the other departments and agencies to inform that plan. I hope it doesn't take as long to produce that as it did to produce the implementation plan for the National Strategy for Pandemic Influenza. President Jimmy Carter issued that requirement to the Department of Health, Education, and Welfare for the strategy and the implementation plan, yet it was only released by President George W. Bush, however many decades later, and pulled away from the Department of Health and Human Services. Just quickly about antimicrobial resistance, the panel is very concerned about antimicrobial resistance. AMR would exacerbate all the types of threats that I mentioned earlier. Our national policy, which seems to focus quite a bit on hospitals and healthcare, looks at these individuals, these patients, and then says we have to get them out of the hospital as soon as we can, because we're trying to reduce their exposure to these resistant organisms within these hospitals. I would leave it to my colleagues to discuss how effective that actually is, but it's not a national security policy. It's not good national policy. If we were to be attacked or experience a naturally occurring disease that has become resistant, that affects a large population or populations here in the United States, we would have no place to discharge them to. There would be no place for them to go. So thank you very much for your time and letting me go over a minute, Mr. Chairman. I appreciate the opportunity.
Thank you very much, Doctor, and thank you for your service.
Yes, sir. Thank you.
Next up, Mr. Curry, you're now recognized for 5 minutes.
Thank you, Chairman Lynch, Ranking Member Heiss. It's an honor to be here today to talk about GAO's past work on biodefense. A lot of what I was going to talk about has been said, so I'll try to alter this a little bit. Biodefense is a very unique threat, and biothreats are very unique in this country. We look at lots of different threats across the government at GAO, and I think unlike cyber threats and mass shootings and things that are in our face every day, it's very difficult because the perception is that these are low likelihood events, and thus it makes it very difficult to maintain focus and maintain resources on these types of events. But clearly, it doesn't mean these aren't serious threats and very scary threats. The other challenge that Dr. George mentioned is fragmentation across the federal government and across all levels of government and the private sector. We've identified for almost a decade now that fragmentation across large and small departments, DHS, USDA, Department of Defense, I think we said before there were almost 24 presidentially appointed officials that had some sort of responsibility for biodefense. They make this very, very difficult to tackle because departments can't tell other departments what to do, and they can't tell them how to spend their money. They also can't tell them how much money to request. This also cuts across congressional committees of jurisdiction, too. It just makes it a very big challenge. Because of this, for almost a decade, we've recommended that the federal government needs a large overarching national strategy and focal point to address this issue, similar to what we've done in other areas like cybersecurity. In addition to the strategy itself at the high level, we've also done work at GAO on a number of more specific biodefense-related programs across the government. And I'd like to talk about just a few of those things. In the area of biodetection, as was mentioned in the opening statement, we've done work looking at Department of Homeland Security's BioWatch program. This is the only system we have in this country that has a goal of detecting a bio threat that's released into the air. But frankly, the system has struggled since the very beginning to do what it was intended to do. It's never done what it's intended to do and never worked as well as we've wanted it to work. So we've made a number of recommendations over the years to try to address these issues, ultimately leading to the cancellation of this program in different ways. It's currently still in use, but is going to be phased out by DHS, but the replacement situation is very uncertain and very unclear at this point in terms of biodetection. In the area of situational awareness, which is extremely important, which is basically how do we know what threat we're facing, how quickly, and who knows it. DHS and HHS have both struggled. On the DHS side, we have found that the National Biosurveillance Integration Center has struggled to get the data it needs and the information it needs, frankly, to be useful to its partners. We heard from the people that use it that it doesn't provide new and useful information. And the HHS side, it's been almost 13 years since there's been a requirement for a public health situational awareness network. That still hasn't been implemented. We've done work on it 3 or 4 different times in that 13 years and recommended ways to try to implement that program. Most recently, in the recently passed legislation, set a deadline for its implementation again and required that HHS implement our recommendations. So HHS has just continued to struggle to implement that situational awareness program. Laboratory safety and security. Another huge issue that we and many others have identified problems with. This is an area that we've identified problems across the biodefense enterprise with all of these departments. We looked at almost every department that oversees or has laboratories, and we found widespread challenges in their policies and oversight. Some policies were out of date. Some suspicious incidents were not even being reported. So we made over 33 recommendations at that time, which is a huge number across departments. 21 are still open. So some departments have made progress, others are still lagging behind. I'd also like to talk about what Dr. George mentioned about the catastrophic incidents, and I'll throw in there situations like Zika in 2016 and Ebola in 2014. What we see in these situations, and even those weren't as severe as the ones we're really worried about, is it's not clear who is in charge when these situations happen, and it's also not clear where the funding comes from. We've done some work in the past looking at development of a response fund. This would be similar to what FEMA has, for example, to handle disasters when they occur. I think people vary on their views of this issue, but some people thought there needed to be some sort of fund so we deal with these issues when they come up and we know exactly who is in charge of these situations. So, we don't have to wait months for supplemental appropriations and things like that. So those are just a few of the issues. I have many more things to talk about, but thank you for the invitation.
Well, thank you. Dr. Kam Delos, you're now up. 5 minutes.
The potential for biological attacks and other naturally occurring pandemics is real and of substantial national impact. And I applaud this subcommittee for addressing this issue. And thank you for inviting me here today. It seems appropriate for my testimony to address the area of biodefense preparedness at the local level, where an appreciation of the likely in-the-field response can be discussed. Over the last 20 years, the University of Georgia and the Medical College of Georgia, I'm a professor in public health in the first and a professor of emergency medicine in the second, we've been active in research and training in biodefense, emergency preparedness, and response. As a result, we've had the unique experience of helping and evaluating over 700 institutional stakeholders within the state of Georgia and their relative ability to respond to a biodefense challenge at the grassroots level. So this program in biodefense was ongoing at the turn of the century, and we got a CDC Center for Public Health Preparedness at UGA, and now it's the Institute for Disaster Management that I direct. For the last 13 years, this institute has had we've led the planning, organization, and conduct of tabletop and full-scale exercises for virtually all the hospitals, 140 of them, and then just as important, or maybe more important, the hundreds of additional supporting institutions, the nursing homes, law enforcement, public health departments. And so, how are we doing? One of the most important developments in this process we've seen in Georgia and is mimicked elsewhere in the country is the development of healthcare coalitions to better coordinate biodefense response between so many disparate institutions. It was very hospital-based for so long, and now we're getting all these support institutions involved. That's been a success story. For instance, we've had, and this was initially started in New York, quite frankly, and the success they've had there has been now duplicated in Georgia, and we hope elsewhere. For instance, there have been many epiphanies where we get these organizations, and for the first time, they divulge their plans to each other. You got to realize these people are in competition with each other in most cases, and all of a sudden, we discover they're depending on the same resources, and they're going to be fighting over them if these events ever occurred. And so we hopefully help them work this out in advance. Now, starting in 2015, the Ebola crisis occurred, and Georgia received a lot of these patients from West Africa. And so we had to ramp up pretty quick, and we quickly realized in our initial evaluations that the 17 service providers who volunteered to provide these services were not ready. It's a pattern that we expect would happen nationwide. It just that we experienced it because we had these patients coming in. Now, these EMTs and docs are very bold, and they're willing to go in, but you've got to train them right. For instance, we just had a tabletop last week at the Institute in Athens where we had all the people from all around the state that would be the actual people that would respond. And there has been progress in that. It just shows that training can work. Now, one of the most vulnerable populations in this anticipated biodefense scenarios we found is increasing elderly populations, especially the ones in institutions, in nursing homes and assisted living facilities. There are thousands of them in Georgia alone. Now, the vulnerabilities that have been seen in natural disasters for vulnerable populations, very highly publicized in the recent hurricanes. As severe as they are, we can expect those to be exacerbated further, much further, when considering biodefense issues, and particularly with agents that are coming in that are microbially resistant. Now, the current system is not robust in dealing with the background. If you've ever been to the institutions, they have background problems with isolating infectious disease people. And then there's evacuation. The evacuation is a nightmare. We've designed evacuation plans from these facilities. Nationwide, it's a big problem. In fact, in most cases, they're just going to be shelter in place because the complications in trying to get them out of there. Now, we've researched new approaches. We've gone into the back of these ambulances and try to ramp them up. A success story there is Georgia EMS. They used to they're going to take 3 hours to transport a patient. Now we can do it in 30 minutes. That is a standard that should be expected nationwide. If we can do it in Georgia, certainly we can do it elsewhere. Now, I will tell you, if you look at a top flight problem, and that's going to be, and we're looking at it now as a backup power for these long-term care facilities. There's some real nightmare stories with that. Efforts are greatly needed now to prioritize and close those gaps in power backup capabilities. I've been talking about it a long time, and it hasn't happened. I'll just tell you, I'm really worried about that one. We've reviewed hundreds of after-action reports throughout the state, and we keep those at the Institute. Two common themes emerge: the need for additional research and training in incident command, who's in charge, how are commands given out, and the need for additional research in communication methodologies. I'll close with just a couple of examples. For instance, emergency codes are coming out over these hospitals. We found throughout the system, they don't know what they mean. They have no idea. It's unbelievable, but they don't. And we have some plans to get off this color code system, and let's make the visitors and patients responders instead of panicked people. And then I'll close with the mortality issue. We wrote the mass fatality plan for the state. I tell you, these rural hospitals, for them, a morgue is a little room with an air conditioner, a window unit. A lot of these facilities only have they'll have maybe a couple of weeks of money on hand. They'll collapse under this pressure. And I might point out that they're also the ones that are already hard hit. This will fall hardest on the vulnerable populations. So we've come a long way, and there's little doubt that with the increasing biological threat matrix, we have a long and I think difficult work ahead of us. Thank you.
Thank you very much. I will now turn to questions, and I yield myself 5 minutes for questions. So I think because of the anthrax attacks on September 11th, I think our response was to that type of event where terrorists might or malign actors might try to inject something like that into the population. But more recently, I don't know, over time that has become a sort of a low. There's been a probability bias that works against us focusing on that problem because nothing's happened since 2001. The more recent manifestations, though, are this antimicrobial resistance that we've seen in some of the hospitals. Dr. Boucher, I think you mentioned that in your remarks. So there have been a number of assessments in terms of the New York Times did a very, very good piece on that. It's made my skin crawl. And we had a report from the Secretary General of the United Nations that estimated that drug-resistant diseases cause at least 700,000 deaths worldwide each year. And the report noted that figure, and I quote, could increase to 10 million deaths per year by 2050. And all the reports say that the figures that they're putting out are very conservative assumptions. What is your assessment of the threat here? We've heard about our preparedness, which is severely lacking. But in terms of trying to quantify the magnitude of the threat here, what are your thoughts?
Thank you very much, Mr. Chairman. I think the main message is that the crisis is here. So antibiotic resistance is real. It's at all of our hospitals. It's in the community. And it's no longer if it comes, it's here. So those patients I told you about, there are more, and all my colleagues across the country are treating patients like this, and we're having the sad duty to have to send people to hospice because we have infections we can't treat. This is happening all across the country.
Yeah.
So I think that's one thing. In terms of our response, through at least my involvement with our society for the past 15 years and the Presidential Advisory Council now for the past 5 years, there certainly are efforts with the National Action Plan for combating antibiotic resistance to coordinate the efforts across the U.S. government, and I think there has been some good progress. We certainly still have a ways to go, and the National Action Plan set out targets for what would happen by the year 2020 for how resistance would decrease, how antibiotic overuse would decrease, a number of hard targets, which we have not met. I think that we have a meeting coming up in July, and we'll have another report released sort of looking ahead to the next 5 years as to what are the big needs. And I think that we still have some really big needs. Probably the biggest need, if we had to pick one, would be to make stewardship programs for antibiotics a condition of participation for CMS, to finalize that rule. So that rule is under consideration. I think a week or so ago it was sort of continued for another year, but we're very, very hopeful that that will be finalized. The Joint Commission has mandated that, so all Joint Commission hospitals have to have stewardship programs, and we've seen great increase across the country in the presence of stewardship programs, and it's making a difference. We need to see more. We also have stewardship needs in the outpatient arena, and the CMS has a condition of participation for long-term care facilities, which are real breeding grounds for antibiotic resistance. So those are a couple of high-level thoughts in terms of where we are.
Well, let me ask you about the pipeline for the antibiotics, because that has to be part of the answer here, right? You mentioned how even the 42 or 46 that are in development now, a very small number of those might address our needs. How do we incentivize that? How do we, on our end, incentivize the research and development that needs to happen?
Great question. So it is true that the antibiotic pipeline is thin, and we've been making efforts for the last at least 10 years to work on resurrecting it a little bit. And while we had a little bit of good news and a few more antibiotics approved recently, we have this sort of terrible situation where the market really seems to be broken, and we had the bankruptcy of a company. So we're finding that the return on investment for antibiotics is just not what it needs to be. And some of the reasons are that antibiotics are given for short periods of time. we hold them, we people like me, hold them as much as possible to be used only when we need them for the worst infections. And, the societal sort of standards are that the cost is just not that high. So we unfortunately have come to the point where this company who developed an antibiotic that we really needed couldn't even afford to continue to manufacture it so we could have it on the shelf in our pharmacy for the time we need it. So that gets to incentives. And so we sort of break down incentives into two groups. Push incentives are those that happen before the drug is FDA approved, and we have a good example, I think, in CARB-X, which is a public-private partnership between BARDA and several other global partners, including the Wellcome Trust and some other academic and government groups. They have successfully funded a number that at the end of this year it'll be over 60 different medicines and diagnostics for antibiotic-resistant infections, and that's really great, and that's helping that early phase. The other sort of part of the story are so-called pull incentives, which cover the time after a drug is approved by the FDA, and that's the area where we're seeing this big problem now with the bankruptcy and maybe some more. Yeah. And so there is where this Disarm Act comes in, and that's one idea of a pull incentive to carve out the cost of the new antibiotic from the diagnosis-related group, the kind of bundle payment that we get in the hospital, and could be a kind of short-term, small step in the right direction. Very importantly, that incentive is tied directly to antibiotic stewardship. So it has to be used in hospitals that have antibiotic stewardship programs, and takes it one step further to actually requiring reporting on use of antibiotics back to the CDC, so that we'll know that these drugs that are incentivized are used in the best way possible. Yeah. Another sort of, we know that more is going to be needed in the pull side, and so the concept of delinkage, that is taking the return on investment away from the volume of sales, this concept has really gained traction in ideas like a market entry reward that might be awarded to the maker of a drug that targets a really great unmet need at the time of licensing and guarantees a certain amount of return on investment over a period of, say, 5 years, again, tied to good stewardship and appropriate use, could be enough to kind of help get this
prime the pump.
Get us back into a functional situation.
Yeah. Okay. Thank you very much. I now yield 5 minutes to the ranking member for questions.
Thank you very much, Mr. Chairman. Dr. Delos, let's just the biodefense preparedness and then the defense management. How is that best coordinated on a local or state level?
The best thing for them to respond, and first, we've made a lot of progress. Exercises help a great deal. The one gap, I'd like to go back to gaps, how do we improve further? It's getting the physicians to come. We have, it's hard to get them, they're busy. To get them involved in the exercises is a key factor for us. I think the key to that is through the CEOs of the hospitals. They can tell them what to do, and if they did, that would help a great deal. Like I said before, the infrastructure support, I didn't even mention it, but these things that make everything worse, the cyber vulnerability of the healthcare system is stunning. Just there in our local vicinity there in your district, there have been a bunch of ransomware attacks that have taken down these healthcare institutions for millions of dollars. And all of this robs the infrastructure. So I would say bolstering the public health infrastructure is the answer to this. And so that when it occurs, and I believe, and I agree with my colleagues here that this is coming, when you say something's, we were talking about it before, when you say something's a low likelihood event, that just, it's not a straight line that we're talking about. It's low likelihood, and then all of a sudden, you're logarithmic. And,
right.
And you're shooting up.
Yeah, when it happens, you got to be prepared at that point.
You got to be ready.
And you mentioned the healthcare coalitions. I'm curious about that in reference to what you're talking about now with the exercises. Yeah. I'm assuming that means not just the hospitals and doctors, but the entire healthcare coalition that you're talking about, which would include law enforcement and a host of others involved. Is that?
That's right, like volunteer groups. And how to mobilize people. They can't show up at the time and help. We have to have trained people. Medical Reserve Corps units. There are all sorts of ways, but it's got to be the community working together. New York showed us the way on this, and it was really phenomenal because it's a false multiplier of all your resources there working together. We've seen, I saw it in Georgia just over the last 10 years. It's just, it really explodes the capabilities. But in the end, if we don't have the drugs, if we don't have the new antibiotics, I'll add to the testimony that was just said, we have a drug development is pretty big at the University of Georgia, and yet we're now telling the students coming up that the odds of you running a drug all the way through the system is 10%. And so these youngsters, they all look young to me now, they're coming up and they're going, I'm never going to run a drug through. And so there's just a lot of disincentivization with that, and that's a major issue. So on the pharmaceutical end, we got to fix it. On the healthcare coalition, we got to continue to build it, particularly the weak links like the nursing homes and assisted living facilities and the power backup.
And in addition to that, I would think there would have to be a partnership between federal, state, and local. I mean, this is everyone working together.
Like we say, all disasters are local, and we sure appreciate the federal government's support because the resources are massive and awesome and really impressive. Although some of them, like you were describing, haven't been very efficient. But when it comes to being on the local level, it's all local, and we have to depend that they can meet these demands at the local level.
All right, Mr. Curry, let me ask you real quickly. I'm sure all of you are aware that DHS has determined that fentanyl poses a significant material threat to our security. Do you agree with that assessment, by the way?
Yes, sir.
All of you, I'm assuming, agree with that. So can something like fentanyl be used as a broader mass attack on the U.S.?
Sir, I think, I'm not sure I'd be comfortable answering that in a public setting. We're not actually doing any work on that specifically, but the issue of fentanyl as a drug and some of the drug concerns versus its use as a weapon of mass destruction, those are kind of two separate issues, and the latter gets into classified information pretty quickly.
Okay, totally respect that. My last question for now, Dr. George, you mentioned the blueprint with 33 recommendations. Who has received those 30 recommendations, and ultimately, who's responsible to implement them?
So we had distributed the report throughout Congress. We issued it in 2015, though, so it's been a while. We wrote recommendations for various federal entities, for the administration, meaning the White House specifically, and for Congress to execute. So it depends on the recommendation. But you know, sir, it depends on what the topic is too. I don't think we should be leaving it to just one entity all by themselves. If the White House isn't going to pick up on something, Congress certainly should. If Congress isn't going to pick up on something, then the rest of the federal government can. You know, it's one of the beautiful things about our government. So that would be my...
As one of the messy things about our government, like you said, Mr. Curry, we've got like 12 different overlapping, nobody knows who's in charge, and it seems like this is something that needs to be addressed. Thank you, Mr. Chairman. I yield back.
Okay, let me stay with you, Dr. George. I know that most nations, almost all, have signed this, biological weapons convention, basically a treaty not to purchase these agents. However, it's a different story with some of these non-state actors, and the technology has really come down in terms of the cost of acquiring it or developing it yourself. What level of risk do you think that our military face? Say, we got folks in Syria, we got folks in Afghanistan, Iraq. What's the level of risk do you think that is presented for them to face what you faced in uniform?
Yes, sir. I of course think it depends on the geographic area that they're located in, but I think that they're at great risk. I think these countries and our troops and everybody else's troops are at enormous risk. When you look at Syria, for example, Syria had a vibrant biological weapons program.
Yeah.
North Korea is suspected of engaging in biological weapons development as well. And Al-Qaeda, ISIL, and other terrorist organizations have been very vocal about their desire to obtain or produce and use biological weapons. And they're not talking about doing that out in the country somewhere where nobody is. You have to take their desires to use biological weapons and look at who they're fighting at the same time. That puts those populations at risk, and it puts our troops at risk as well.
Let me ask, Mr. Curry, and also Dr. Delos. So the response in its initial phase will be local. So that means my local community health center in my neighborhood. In a lot of rural communities, it's probably a local community health center. It's our docs and nurses, EMS, first responders. That's the front line of the program we have right now. And so how do we engineer our response so that we push out some of the countermeasures to that population, to our first responders, to our local health centers, to the people that are going to have to respond to this in the first instance?
Well, I think one thing I'd like to say, this is where I think health situational awareness becomes so important. So you're right, the nurses and docs are the ones that are going to see the information the fastest and right away. But at the federal level, this is why these information networks that DHS and HHS have been developing are so critical, because the idea is that we need to have them tied into all the state and local information to get that information as quick as possible, not just to diagnose it and understand what's going on, but then quickly communicate to everybody at all those levels that need to come in and help surge and respond. Yeah. Otherwise, it's going to remain localized for a long period of time before the word trickles up to whoever it needs to trickle up to, and then trickles down very slowly. And that's our concern about the lack of progress on these situational awareness networks.
So, Dr. Boucher, you're at Tufts, and we have an event like this, and as Dr. Delos points out, and Mr. Curry, the initial impact is really on the street level. How well are we equipped to connect what you're doing and the resources that you have, and are there exercises that go on here that we coordinate, the local community health center with Tufts or your research arm and the labs that are working on this?
Well, I guess I can speak to what happens at the hospital. So we certainly have exercises that are ongoing, and we work with the city and state Department of Public Health, which are tied into CDC. So I think we learned a lot from the Ebola experience, and it wasn't smooth when it started, but certainly I think that we have these tabletop exercises regularly, and there's participation with community partners as well as a hospital like ours. We're a quaternary referral center, but we also communicate across town, and we have different, lots of different players in the medical world, but the state and local health departments really are the center and do a great job. And so both in sort of this really kind of dreaded disaster preparedness, but also in things like the opioid epidemic. Yeah. We're working together in that way too. So I think that that's the vision from our CDC colleagues, is that it works local, state, health departments up to CDC and back. Yeah. At least for surveillance and initial response in that regard.
Can you comment on that? I mean, your initial testimony, I meant to go back to that, where you talked about, repeat opioid use, contributes to this vulnerability of antimicrobial resistance. What's the connection there? I missed that.
Okay, so people who inject opioids get infections because they're injecting through their skin. Yeah. Even if their skin was clean, they'd have an increased risk of infection. And we know that patients who use opioids have a 16 times higher risk of having an MRSA infection, which is a resistant kind of bacterial infection. And so what we're seeing are patients like this, unfortunately.
Is that shared needles? Is that?
It's not even. I mean, it could be. It could be worse with shared needles, but just injecting, every time you injecting your skin, okay, even if it's sterile, there's still a risk, right? The skin is our most important barrier to infection. Right. So these people are injecting over and over again, usually not in such a sterile way. So, but we know from good studies that these patients have a 16-fold higher risk of MRSA, and that's just one kind of resistant bacteria. But our hospitals are full of these patients, and treating them is incredibly difficult. It's heart-wrenching. These are young, otherwise healthy people. I'm talking about doing a heart valve replacement and another one and another one. I mean, it's incredible, the burden of that morbidity and mortality. that we see. And so our society now has a whole group dedicated to infections in people who inject drugs because it's such a big problem. It's almost a little bit like the beginning of the AIDS epidemic in terms of what we're seeing and the burden of it, the stigma of it, and the challenges, the sort of multidisciplinary challenges in treating it.
That's great. All right. I'm going to yield to the gentleman from Georgia for 5 minutes.
Thank you, Mr. Chairman. Dr. George, I know the Blue Ribbon panel has had some meetings and has published some stuff involving the private sector being involved in the preparedness effort, similar to what Dr. Delos was talking about. Just comment a little bit of how the partnership works between the private sector and government.
So it depends, of course, on the topic, I guess. And I know I keep saying that it
But just an
depends.
example.
Well, I think when it comes to pharmaceutical development, for example, the federal government has identified various threats, various biological threats that we would need antibiotics and other antimicrobials to address. And they need to fund those things that we don't have a market for. So that would be on the one hand. On the other hand, the United States government is not in the business of producing antimicrobials by itself, so it has to work with the private sector. And together they have to produce what is needed for the country.
Okay, so in that scenario, you're talking private sector would be the corporate, the business sector. Okay. Coming back, Dr. Dallas, to you, the national biodefense structure that the president has come out with, do you see a pathway in that for better collaboration between federal government, federal agencies, and state and local?
Yeah, like was said earlier, it was a good start, and it was a long time coming, but it is a good start, and I'm encouraged by it, frankly. We've got to do something to get to bolster this the private sector's incentivizations. For instance, the vaccine development is a perfect example. We've almost chased the vaccine development out of the country, even when we provide incentivizations to these companies. Oh, you know what their main objection? Lawsuits. They said, look, we can't, we can make Tylenol or some other agent and make lots of money. The liability here is too high. And say, well, we'll protect you. And they say, I don't believe you. and they've just withdrawn, even when offered what they say is legal protections. Yeah, I am encouraged by the new device. I'd like to see it move forward. Like was said in other testimonies here, there's often some real latent periods. Some of them go on a long time before we see a response. But yes, I am encouraged by it. Okay. I would really like to see us incentivize these companies to move forward, and I mean right away. Good
suggestion. All right, I want to come back to earlier. You mentioned the one of the things that you didn't phrase it this way, but keeps you up at night, is the vulnerabilities that we have, particular in particular with the elderly senior community. All right, so we've got all these facilities out here. We've got hundreds of thousands, millions of seniors living in them, and private homes, a host of different places. What's needed to bring these facilities up to standard? I mean, it sounds like an enormous task.
It helps that most of these facilities have isolation capabilities now, okay? It's just that they're operating on the edge. They're operating in a margin, and they don't have the incentives either to further develop these isolation capabilities. So we ought to take the isolation capabilities we have now and exercise them. And otherwise, what we'll end up doing is if they get to the hospital, they'll get care. If they don't, they won't get care.
All right, before you go,
it's really dangerous.
For my help, all right, what are we talking about with isolation capabilities?
Well, that usually means they're laughing over here with me. It usually means we have a little room, we stick them off.
All right, that's what I had pictured in my mind.
And we have a $10 an hour person that has no training that is expected to keep them from infecting the other people, and they don't succeed, and then it spreads, and then we can't move them, because if we move them, we'll then contaminate the bus driver and the personnel. So yeah, it's to take that simplistic, very basic, almost 19th century, I shouldn't have said that, but system that we have and advance it. Just let's bring it up to the 21st
Yeah, I
century.
mean, and that's got to be an enormous thing. I'm thinking a little room as well. If you've got an entire facility, a senior citizen facility where you've got something spreading, they're not going to all fit in one room. I mean,
Yeah.
this is it's yet another disaster waiting to happen.
And the rural areas are where the real issues are because they're on the edge. These are the vulnerable people. They're already on the edge, I mean, frankly, on the edge of healthcare access. And boy, when this comes, it's going to hit them the hardest because they're on the edge. And then, like Mr. Curry was just saying, you know, we're the frontline people and we're showing this information. We can't really tell what's going on. We've got to have a central, you know, organizing people to say, look, there's the problem, and then they come back and tell us what to do. But I'm telling you, these nursing home and assisted living facilities, particularly the ones that are on the edge now, there's where things are going to explode out of there on us.
Well, we'd appreciate if you'd fix that problem real quickly.
Yeah.
Thank you, Mr. Chair.
We'll do our best.
All right. I mean, that goes back to my question regarding the community health centers, because I know a lot of rural communities love their community health centers, but I'm not sure that anybody on the ground within that health center is thinking about this problem. And I'm not sure we've incentivized them to, you know, to do that.
We have a lot of highly motivated people in public health departments, and people forget about them. And they're really motivated. They're just do-gooders par excellence.
They are.
But they don't have the knowledge. Somebody at the central level has got to shoot information back to them, say, you've got to watch, you've got to isolate, or you've got to move them out.
Yeah.
They got to be told, and then somebody better get down there to help them, and we're going to have to force them to have evacuation plans,
Yeah.
and then back them up.
I actually, you know, so we had a suicide cluster in my neighborhood, my local neighborhood. We lost 14 young boys over about 18 months. And it was my local health center. It was the Massachusetts Department of Public Health. And then we reached out to CDC in Atlanta. And so it was that whole network, sort of what you're describing, for a different type of problem, but it was very much a scramble until we got the right people in place and had an opportunity to address it. I want to ask each of you, so you each got about a minute and 15 seconds. What else do you think is important for the ranking member and I to know, and members of the committee to know? What else do you think is very important for us to understand? I mean, we have your written statements, so I know you've got your top 5 ideas, but what else is out there do you think is lacking that we might need to address, or something that might not have percolated up in our discussion already today? Dr. Boucher.
Thank you very much. I'll comment on a couple of things quickly. We didn't really hit that much on diagnostics, but an area where we really are on the edge, I think, of making some big advances are on diagnostic tests. So that's an ability to know if a patient has a virus or a bacteria causing their infection, or if it's a bacteria, which bacteria. If we knew that, we could impact this problem of resistance, we believe, in a really meaningful way. And so there are efforts going on in that public-private partnership I mentioned is funding some diagnostic companies, but there's still work to do on the path to approval and marketing and using them in our hospitals. Another area that I don't think we probably highlighted enough was the One Health approach. So we understand that the problem of antibiotic resistance really flows between humans, animals, and the environment. And we in the United States have made some good progress with our food animals, with the veterinary feed directive that was passed, sort of banning the use of antibiotics as growth promoters in food animals. But this problem on a global scale is huge. The amount of people in the world who are going to be eating meat is going up and up and up. And we know that a lot of resistance comes from the developing world to us. So this interrelationship is very important in the way we address this problem. And this is something that we're focused on in our center in terms of research. We're studying things like passing of resistance from your pet dog or cat to the family and back and forth. And there are a number of issues here, as well as in the environment. So I think we want to highlight that. And then the last thing I'll mention is the workforce. We need a robust workforce to solve this problem. We need doctors, of course, which is my bias, but also we need nurses and pharmacists and others. So we at IDSA and others are highly engaged in things that will help us recruit and retain the best and the brightest in this field and ensure that they're remunerated adequately to stay in the field. So thank you.
Excellent. Dr. George?
Sir, I would just mention two things in particular. We talked about information flow earlier. I think it's important for you to realize that there's an intelligence issue here as well. The intelligence community has not dedicated a whole lot of resources to this particular threat since we shut down our own offensive biological weapons program back in the 70s. They have to step up, but we're talking about diseases and activities that are occurring on the non-classified side as well. So that information intelligence fusion has to happen, and then information has to go up and down so that it's usable by state and local folks. I would also mention, too, that it's important for you to know, if you didn't already, that the public is actually very concerned about the biological threat. One of the reasons is almost everybody's had some issue with antimicrobial resistance, of course, but many know people who have received white powder letters and packages. And also, I think it's important to understand that Hollywood has picked up on this, and they keep churning out these movies that put the biological threat front and center to the public and keeps it on their minds. So we owe it to the constituents to actually do something about this and move the the stick forward so that they feel better protected.
Very good. Mr. Curry?
Yes, sir. I know we're running out of time, so I'll just limit it to
No, you got time.
Okay, I have two things. So the first thing I'll say, just for you as the chairman and the ranking member, you mentioned congressional oversight. I think Dr. George mentioned congressional oversight. We think the strategy, we're looking at it right now. We're going to report on it later this year. I think it is one of the best efforts we've seen so far, and we've been looking at this for a long time to better coordinate biodefense. But consistent oversight is going to be critical to keep this moving forward. We see across government, we look at everything there is in government at GAO, and where there is heavy oversight and heavy emphasis, progress gets made. And I think the execution of the strategy is going to be critical. And there's going to be some really difficult things in that execution. I mentioned the prioritization of resources and budgets across so many departments. It's going to be a huge challenge to be able to look at that holistically.
Mr. Curry, you're actually, isn't the GAO currently reviewing the report that Dr. George referred to earlier?
Yes, sir. We're currently reviewing the National Biodefense Strategy to both ensure that it met the legislative requirements and also to see if it's going to be successful when it's implemented.
Okay.
And so that's exactly what I'm talking about. Is that it's got to be successful in the execution, but it's going to be a major challenge, and it's not going to get implemented successfully just by the departments without consistent congressional oversight.
Excellent. All right. Is that all you got?
Yes, sir.
Okay. Dr. Delos?
Yeah, I want to jump right on that along with Mr. Curry. He mentioned about congressional oversight. I'll give you a perfect example. And the progress that we made in Georgia, we had this influx of Ebola patients coming in. The way we were able to make progress was because there was congressional oversight language that we could get back to that controlled how the Ebola funding was done. Now, as we all know in here, when there's government appropriations, people want to send it off in all sorts of directions. But since there was very firm congressional oversight language, it really made a path for us. And that is probably more than any other single factor, other than our enthusiasm and running around in back of ambulances, was the fact that there was congressional, and every time we got lip service. No, the congressional language says this, and then that made us. And that's what I saw in person. That's how we made the progress we did.
I do know that on the Ebola issue, that we had asked a certain number of institutions to raise their hand and say, if we're in this situation, we're in. Yeah. And so, to those courageous institutions that volunteered their services and said, we want to be part of this and we want to step up. The only problem was when it did happen, many were unprepared. They were very willing, yeah, but they were woefully unprepared. And so that's sort of the gap between where we want to be and where we actually are. I also have I'll get some housekeeping here. Do you have, yeah, absolutely. Go right ahead. I yield to the gentleman for 5 minutes.
No, I won't need 5 minutes. Dr. Boucher, I just have not been able to ask you a question. And I guess the one that I have remaining for you is how can we reduce the rate of unnecessary prescribed antibiotics?
That's a great question. So we believe that there are a number of ways to do this. And so antibiotic stewardship, this programmatic approach to the most optimal use of antibiotics is a great way. And it involves, a program that exists in a hospital or healthcare system to ensure that antibiotics are used appropriately, that is, not used when they're not needed, and used in the best way possible when they're needed. And that's really important because using them in the best way has better outcomes. We have learned a lot, I would say, in the first 5 years of the National Action Plan about what impacts behavior, why physicians give antibiotics to people with colds. We've learned that good studies have shown that if a patient comes into the doctor's office late in the day, they're more likely to get an antibiotic than if they come early in the day. There are a lot of issues at play. And so actually, we've recommended at the Presidential Advisory Council more work on implementation science. How do you actually get it to happen? How do you get people to change their behavior? And I think we're making strides. There's been some good progress in pediatrics. There was just a study this week about emergency rooms, having stewardship programs in emergency rooms. That's a place where a lot of antibiotics are handed out, and then urgent care centers or other target places. So there's a lot of work to do, but I think that probably it's going to take a little bit of carrot and stick to make it actually work, and some better science to know what will not only work but be sustainable. Because that's the other thing we've observed is that some programs work and you get the numbers down for a while and then they trickle back up. So I think that clearly physicians, other prescribers, all of us have a role, and then every patient has a role. I encourage patients to ask, do I need this antibiotic? If every patient asked that, we'd be a lot further along in the trajectory.
Well, listen, I just want to personally, again, every one of you say thank you for being here. This has been extremely informative to me personally, and I'm glad no one sneezed in here today. But this has just been great, and your expertise in bringing that here to Congress is very helpful. And Mr. Chairman, to you as well, thank you for calling this hearing and putting this together. I appreciate it, and I yield back.
I thank the gentleman, and I would like to just follow up on your excellent question. I spent a little time a while ago in Honduras and in Guatemala and in El Salvador, and it was on the immigration issue. But during my visit there, I learned that many of the antibiotics that we use, the most popular ones here in the United States, penicillin and others, are available over the counter in those countries. So people don't, they sort of buy them like we buy aspirin. And so, it provides a training ground for some of these germs, and it just reduces the efficacy of those antibiotics. Is there any sort of international or regional cooperation going on with some of those countries where we could work with their health departments and maybe try to educate everyone on our effort here and how they might sort of get on the same page, and maybe we can help them with some of their issues as well?
Huge issue, the over-the-counter availability of antibiotics in much of the world. And I think the plan is the Global Action Plan for Combating Antibiotic Resistance. So it came out of the UN meeting a couple of years ago. And the good news in the WHO is sort of leading that charge. We're very much committed to and part of that. The good news is that many countries now have an action plan. The challenges are that in many developing countries, access to antibiotics is a much bigger problem than anything else. They have babies dying because they don't have access to antibiotics, and they don't have a healthcare infrastructure to have doctors, nurses, anybody prescribing. So I think it's going to take a lot to change this. Certainly there are efforts in every country as part of this action plan has to have some kind of a stewardship program. It's going to be very different, right? And for some countries it might it might be taking antibiotics away from over-the-counter status, but it's a huge issue. That access piece globally is very different than what we have here in the United States.
Right, more complicated than I thought. I have a little bit of housekeeping here. I want to ask unanimous consent to enter into the record a statement from the California Life Science Association that was offered by Mr. Ruda, right? Without objection, so ordered. Lastly, I'd like to thank you all for your patience and your very, very helpful testimony and the good work that you do on a regular basis in your official capacity. Without objection, all members will have 5 legislative days within which to submit additional written questions for you, the witnesses, through the chair, which will be forwarded to the witnesses for responses. And I ask, if you do receive any of these questions, could you please respond as promptly as you are able? With that, this hearing is now adjourned. Thank you. Thank you, Mr. Thank you. Thank you. Thank you.
Watching that BioWatch program.
You've had a long day.
And it's just awkward.
Catch an interview.